with good friends, and in this case, more than a good friend. We speak every day. You know us for a long time. You know us for more than
Maybe,
30 years.
in fact, more than 20 years ago.
More than 20
Yes.
years.
Hello. Thank you, Rui. It's a pleasure to be here with you. You don't remember, but my first implant surgery, you were there. You don't remember. You made it. I helped you. It was a dental clinic here at Oporto. Maybe it was in 2004. The
2004.
first dental implant that I helped was with you.
I
So
thought in
I give you this
2004.
information.
I thought in 2004 I was still on the university, but maybe not.
No, you had just left, and I had just finished my dental degree, and so I went to that clinic, and you were there. You put the implant in 5 minutes, and I got astonished with that. One day I will be like him. So we are here today, 20 years after.
Great.
that.
So Carlos is he does maxillofacial surgery, and today we are going to talk about mostly individualized solutions. Since Carlos is one of the users that uses for nowadays almost everything. You talk about digital planning, right?
Yes. In fact, today the gold standard for me it's virtual surgical planning. It's all about that, efficiency, precision, individualized medicine. So if we want to perform an excellent, outstanding surgery, we have to plan everything. I'm not talking about guided surgery. It's not that. It's planning, diagnostic planning.
Yeah.
Because I enjoy freehand surgery, but the planning is essential, and virtual surgical planning is the gold standard for me today, even in oncological surgery.
Mm-hmm. Yeah.
I have the pleasure to work at our hospital, a public hospital at Portugal, Porto. It's one of the biggest Portuguese hospitals, and I have the privilege to work with amazing surgeons. For me, they are the best surgeons in the world.
Yeah.
I work with ENT, plastic surgeons, and we work all together in order to give our patients a better quality of life with minimal invasive procedures.
Yeah, I know. Yeah, that's always on your it's your focus always.
Yes,
to
as
open
simple
as
as
it
possible.
can be. Yeah.
Yes, always as simple as possible.
Yeah, great. So, Carlos, you have started this trajectory of individualized implants almost. It was not with me, I know.
Yes, you were not the first. I started maybe 6-7 years ago with another brand. It was a very well-known company, Wild World Distribution, and I've made my first case with a friend. It's a great surgeon with me. His name is Nuno Gil, and we performed the first individualized implant.
Do you want to show us?
Yes, I have that case here. It was a very favorable.
And you go along. It's this one.
This was a young patient, very young, 20 years maybe. She had a benign tumor, but we performed this surgery, this
Large
resection,
yeah.
and we did this oral rehabilitation, and the patient still has this implant today without any complication. I did this picture a few weeks ago during prosthodontic maintenance, and this is the aspect. So we are talking about a very good solution, and this was my first case. Then we talked about these cases. I searched for this company for I've made an international search without
And-
knowing that you had a Portuguese company called Bonizi, and when I found out, I called
It was
you.
a real counter.
I called you, and in fact, your company was much ahead of this well-known company because you had knowledge for dental implants and all the platforms, all the screws, all the
Yeah.
the multi-units, everything was much better than this company. But this is a great company, and I love this case and working with you.
So then you started with me, your first.
Yes.
And
Yes.
what you felt different at the time was.
Well, the main difference was the quality, the precision of the screws, the precision of the attachments, and all that meticulous and professional adaptation for the prosthodontic rehabilitation, because I also, at the time, I used to do the oral rehabilitation of these patients, was much better than the other companies that are very good, but are not as good.
Focus on dental.
Yes, focus on dental. They are good on plates and screws and.
Traditional oral
Yes,
maxillofacial surgery.
Yes,
yeah. Okay.
yes. But we did another different cases. This is another one that I can show you this video.
I remember this one because it's a very special, and probably lots of people will get completely astonished with it because you never expect that you could use an individualized implant to make one tooth only.
Yes. It's not. I don't do this for routine. I don't have any problem doing grafting and all that kind of surgery. But on this case, the patient wanted a fast treatment, simple treatment without bone grafts. So I decided to study this option, and for him, he agreed. You agreed. We all
Yeah.
agreed, and we performed this case. As we could see, that he had no bone for dental implants. He had a sinusitis also because, and that's why we choose this kind of
Solution, yeah.
solution.
In reality, it's
And
true. Lots of people has lot of.
You can see here the case. Nowadays, I don't perform the surgery like this. It's too much invasive. The flap is very wide, and nowadays we can do this with a simple way. But it's
Also because you also help us to change a little bit design direction of the
Yes.
screws, and we improved a lot with your help, of course. I forgot to tell that Carlos is a clinical advisor from Bonizi, and it's true. Carlos is that type of person that says, which was great, but, and that's good because it makes us improve, you know?
Yes. Even today, I did a surgery, and we're talking about that, and maybe we can show that case later, because there are always things that we can improve. Yes, but this patient has about I think it has about I did it about 4 years ago. He's super satisfied, and the crown is
Yeah, very
It's doing
stable.
well.
Yeah.
yes.
Okay.
Yes,
So-
but that's not the regular indication for me. We have other options.
So usually use this for full arch, right?
Yes, full arch. It's
yeah.
much better. Very atrophic jaws.
Yeah, sure.
Cow with the ALS scale, grade 6 or 5.
Also reconstructions. In reality, we pick up lots of this design for this big reconstruction, maxillary or mandibular reconstructions also.
Yes, I can show you our
Sure.
first case with the full arch. I'm sorry. Okay. Oh, we presented a case at our European meeting one of the first cases. This is a patient that had been operated several times with sinus augmentation, bone grafting, and nothing worked. When she came to me, she came with a sinusitis and without bone for conventional implants. So we studied this option, and these photos have 2 years when we presented the case, and at the time this patient had maybe 4 or 5 years a follow-up.
Yeah.
So it's an excellent result, like conventional dental implants,
Sure.
without with a very good gum, and it's very happy. This
Yeah.
patient had I think 80 years.
Of follow-up already, yeah.
It was a-
Probably MC, because it's one of the first designs that we used to do. We have changed it a lot from that.
She's from Netherlands. This
She's from
patient,
Netherlands, okay.
yes, and she did that implant on the right jaw, there.
Uh-huh.
Yes,
Okay.
you don't see that very often.
Yeah.
Yes.
So, and after this one,
Yes,
we have,
I have a few others. This was a special patient. It was referred to me by a colleague, Luis and José Figueiredo. They perform a lot of implantize with you, I know, but they sent this patient because she had made
Quadrigoma.
several
surgeries.
several surgeries, bone grafting, zygomas, and she had a facial fistula, and she lost a maxilla, a support of the lip, and it was a very nice case because we could see a nose.
Yeah,
inside
you can
the
see the
mouth.
turbinator,
Yes, she
the
couldn't.
medium turbinator. Yeah, right.
She couldn't eat. She couldn't speak. She couldn't drink.
Yeah.
And this patient has a very high position in an international company, so she was doomed because she couldn't work.
Yeah.
She travels all around the world, and she couldn't work. She couldn't eat. She couldn't drink. So it was a very special case. We performed this surgery.
And
I
you
think 2
can
years
see
ago.
from the scars the several attempts of closure.
Oh,
You can see it clear there. Yeah.
yes. We have aquí our planning and all your work with this patient. We discussed a lot. We searched for the best bone density,
Yeah.
the best anchor for the implants, for the screws. It was a very. We thought about this case if it was possible to do the oral rehabilitation, if we should only solve the
communication.
the nasal communication.
Then you got the implants that is still. So from one side, she still had 2 zygomas, which you remove, or did you cut it? I don't remember.
We remove it.
Oh,
We removed it.
you were able to remove
Yes,
it. Okay.
yes, during the surgery we removed it. Yes. Now she's happy. I saw her last week.
Really?
It's amazing.
Yeah.
She gave me a big hug. It's amazing what we can receive from these patients. They are very grateful to us, and we are grateful
Yeah.
to them.
They have
It's amazing.
they went down to hell, and
Yes.
they could come up again. No, it's
Yes, yes.
quite like that. Yeah.
Yes, I can show you the picture.
Right? You can go.
Yes, this is 3 months post-operative, and now she has a full denture, and she's
Yeah.
very happy and satisfied. It was
Amazing,
incredible.
yeah.
Case.
I mean, so
Yes.
you. I saw that you move a lot of buccal tissue
Yes.
to cover that,
Yes.
and okay.
It's,
Uh-huh.
This kind of surgery has a lot of several aspects, several small steps. So we perform a lot of local flaps with buccal fat pad, and
Sure.
we need a lot of good, healthy tissue to close everything.
I,
Yes.
the problem of these patients that have received quadrigomas, it's hardcore to try to close these because the amount of communication is huge. You have big loss of bone, palatal bone,
Yes, yes.
sinus wall, and everything.
Yes,
So
it's very
you don't have support. Usually, you need to be a very good surgeon to be able to close all these. No? So
yes.
congrats, it's an amazing
Yes,
case.
yes, yes, yes. Yes. So, yes, but this is, for now, we have talked about the simple cases.
Yeah.
We have a lot of more complex cases like this one. We presented also at this meeting, international meeting. This is an oncologic patient. We performed a maxillectomy. We performed this surgery with a very good friend and amazing surgeon. She's called Helena Silveira. We performed this surgery together, and
She's a ENT.
she's a ENT. Well, we both belong to the
Same group in the hospital.
oncological group at our hospital.
Okay.
So we work a lot of times together. Me, Helena, and Ricardo Horta,
From
Antonio
plastic.
Ferreira from plastic surgery. We work very. We are all days together discussing these cases and the best option for them.
It's a pity because we don't have much time, but the call for deciding to close or to making obturated prosthesis, or for example to make a flap for reconstruction of a nose or making an epitasis, there is lots of things that we can go around this and to have decisions. It's a pity that we cannot decide this, but in this case, one of the big advantages is that you can control it all. For example, if you are having some new points that you can have tumor again or something,
Yes, it's
very good to
important.
control. You know?
In this case, we choose it to this solution because we can see and follow up and to do the surveillance for the disease, because it's very important. We close only with the buccal fat pad on the maxillary sinus, and we left the nose for open, and we put the denture.
Again, you can
That's
control
why.
it all.
Yes,
Yeah.
we can control the disease. It's very important.
Yeah,
Yes.
very nice, very
Yes.
nice result.
Yes.
So, and we have done, and about
Yes.
this, then
Oh, this is the
this
patient.
is a case that you
similar-
have decided to close,
Yes,
right?
This is the patient from today's surgery. So this is fantastic because we can do this surgery almost a daytime surgery. An 80 years patient with he lost his maxilla due to a cancer also maybe 15 years ago, and he doesn't have any teeth since then.
Yeah.
The denture was not okay for him, and he asked me for a new solution, and we performed today the surgery, and I can show you the closure if you want. We performed this traditional implantize, one single piece. It's very well fitted to the jaw. It's very important. We cannot have any movement, micro movement.
True.
And then we made a temporalis muscle flap to closure the rest of the opening of the maxilla.
And
So this was
finishing
from a
is
today case.
oral nasal communication,
Yes,
no?
yes,
Which
yes.
is really great. I remember that patients report so many things. You say, I put food in my mouth, and I don't know if I'm smelling or if I'm eating. It's such a all these episodes they report. It's really incredible.
Yes,
It's
yes.
really good for a patient to be able to live now like this. It's a second opportunity in
yes.
reality.
Yes. Well, another case that we presented at the meeting. This is a mandible case. Also, this is a benign tumor, odontogenic myxoma, an aggressive disease. And in selected cases, we can avoid a free flap with a simple solution. We did this case, I think, 4 years ago. Nowadays, we don't do this kind of approach. Usually, we try to do it with an intraoral approach. But at the time, it was a good solution, and we performed this surgery for this young patient that didn't want to collect the fibula.
Yeah.
To do
We all
this.
the scars that left now, right?
Yes, 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 yes.
Yeah, it's really good to have this solution always.
Yes.
Oh, I remember this case. Please tell us.
Oh, this was one of the most challenging cases we had at our hospital. This patient with half of skull and face, she born this way.
Yeah, it's a congenital defect.
And
yeah.
we thought about how to rehabilitate this patient. She's still being treated, okay, but we performed this surgery 1.5 years ago. And you can put the next slide to see the
planning.
facial skeleton. Yes. She doesn't have the ear, the orbit, the nose, the maxilla, and the mandible from the her left side. Okay.
So we try to do a mirror, try to get it, but in reality there is a plastic surgery. I remember this patient has done also a flap from. She has made a flap also, a scapular flap, right?
Yes, she made
Yeah.
a scapular flap, suprascapular flap.
Suprascapular, yeah.
Yes, because we need we need more tissues to the face. She had not enough. She have been submitted to multiple procedures, surgical
Before,
procedures.
yeah.
Yes, a lot of them, and we have to. So there was a lot of fibrosis. We have to remove the
Small parts of
grafts
yeah.
from the rib. She had a
Yeah,
lot
right.
of. It was a long story for her.
Yeah,
We are still rehabilitating her. Now she's doing an orthodontic treatment, and after
yeah.
that,
On the left, on the right
yes,
side, yeah.
yes. And after that, she will start the oral rehabilitation for the prosthodontics.
Yeah, but very thin tissue. That's why
Yes.
suprascapular flap was very important on this case
Yes, we have made
to get the symmetry also.
yes
Symmetry.
That here as a simple locator system that you
For the epitasis,
that
yeah.
you designed very well. She has a silicone here. Yes. Oh, this is an X-ray. a
All the
simple
hardware,
X-ray.
with all
Yes,
the
yes.
hardware, yeah.
Amazing this picture. Okay.
Yeah, she's
TM
a-
also the TMJ and everything. It was a very beautiful surgery. I loved it. A big hug to my good friend Ricardo Horta. He was there. We did it together. It was amazing this surgery.
And let's pass it to no. This is the passion. No,
This is
this
one
is
of
the
my
passion,
passions.
yeah.
Yes, orthodontic surgery. Yes, yes. In fact, I started with oncological surgery, and I didn't have a special love for orthodontic surgery. I thought it was too much aggressive, and it was limited to a number of a small
A
number
few
of
people that have really
yes,
large
yes.
defects,
Yes,
orthodontic defects.
But I met a colleague. I was with you at Madrid, remember, 2002, and we met David Zil,
Yeah.
a Brazilian guy, a very top level buccomaxillosurgeon, and we have been talking about customization and virtual planning of for this kind of surgery, and I got amazed, and I performed this surgery. It's not a minimally invasive surgery, but it shows what we can do with virtual surgical planning. At the time, for me, this is not a good surgery now, because I'd rather to do a much less invasive surgery. But as you can see, the four at the maxilla and the
All
osteotomy.
mobilization of the
Yes, yes,
both jaws.
yes,
Yeah.
and also genioplasties. This
Yeah.
patient also did that. So it was everything free.
Yeah.
This is only possible with virtual surgical planning and customization, and now now we are applying that to
All of
minimally
the place.
invasive surgery. I went to Brazil I've been with Jonathan Klaus, and he's amazing. One of the best surgeons in the world, if not the best. He's amazing.
Yeah.
He's amazing. He
Which we are going to meet in 15 days. Yeah.
Yes, in 15
Again.
days we'll see him
We'll
again.
meet them
and
again, yeah.
And the Mateus
Yeah.
Spinella, and all his team is amazing. They are amazing.
Yeah.
I never saw that kind of
Mhm.
surgery. Yes. And we have a lot of very good surgeons here at Europe, very good surgeons. We all
Yeah,
know.
but the concept of big minimal invasive using custom, and it changed a lot
Yes.
the whole view that we have about
Yes.
orthodontics. It changed about the sequence, for example.
Yes.
And we do a lot, and with you also, we do a lot of digital superposition between the planned and the final result.
Yes.
And for us in Maxilla, it's 99.9%.
More, it's 100%.
It's incredible. It's
Yes,
really,
amazing. It's
really incredible.
Fabulous.
Yeah.
So
Sorry. So, talking about
this is
minimal
very
invasion.
important. It's
Uh-huh.
Van Gwen. Oh, the papers from Alfaro, they talk about everyone knows his papers. They are fabulous.
Nelson
And
Leon
this
also.
for me, this is one of the best papers in the world about minimally invasive orthodontic surgery. That's why I put it here. I recommend everyone to read this. It's fabulous. This is his book, amazing book also. Yes. Oh, this is his concept. As you can see, that's a conventional approach, and we can see the lip. And if we compare with the next image, with a small incision, we preserve the mimic, the facial muscles. So the patient has a natural smile with this approach for orthodontic surgery. For me, it's very, very important. And this is the kind of incisions that Jonathan put in his paper. As you can see, very, very small, smooth, soft, delicacy with the tissue. It's very important.
That's what it will allow fast recovery, right?
Yes. Fast recovered, or daytime surgery.
Yeah, and
It's-
also expecting that the plates, by being customized, they bring with them the code of position already.
Yes. In this image, they are not customized. It's
Yeah,
also
these
possible
are-
to perform this with traditional plates, but I'd rather the customized. Today, I only work with customized devices and surgical guides. Well, this picture is to show that we need to change the osteotomies. Sometimes we can see the mandible is not as good. We can feel
The top of the
yes,
osteotomies,
the
yeah.
top of the ostomies. This is an image from Jonathan Klaus. So we changed the osteotomy similar to this, and we can adapt it to the different cases. It's much better, this kind of osteotomy, and it allows us to do a small incision with this angulation.
Not only that, but we have been talking about this lots of times. The V shape of the mandible, if you do a traditional Overgeiser approach and you don't do the osteotomies on the retromolar region, what happens is that you always giving torque to the condyles.
Yes, it's very important. We must be careful. We all know, and virtual surgical planning allow us to see that, to eliminate, to cut the bone, to
Yeah.
Yes, very important.
Yeah, and we notice that a lot because we receive a lot of cases that they come with plannings already of movements, and we see the torque and the movements. It's not really important movies that are clockwise or anti-clockwise, but the ones of that can twist the condyle. It's awful. They finish
Yes.
to the surgery and the patient starts immediately with TMJ syndrome. So
Yes. Well, I like a lot of temporomandibular disorders and the TMJ, but in my opinion, TMJ is one of the most
complex.
no. I think it's more simple than it looks,
Uh-huh.
and we have a lot of articulations.
Joints.
In joints. Sorry for my English. We have a lot of joints in the body. I think TMJ is one of the strongest. So I believe that we should treat the tissues well, the TMJ well, but I also believe that TMJ is one of the strongest joints that we have in the body. Okay.
Yeah.
I started when I did the dental degree. I started with temporomandibular disorders and orofacial pain.
Mhm.
That's why I like minimally invasive surgery, because if I do a small cut,
You
I
cut
preserve
fast
the nociceptive
Yeah.
receptors. I don't damage the tissues, so I have much less pain.
Sure.
And about TMJ, today we all know that conservative measures are much better than aggressive surgical
Yeah.
procedures,
For sure.
and we must have attention, caution with TMJ, but I think it's one of the strongest joints that we have.
Mm-hmm. Okay. By the way, can you
Yes.
explain us something here about the concept of minimal invasive and
Yes.
the guides that we use? Maybe we should pass the image to here, and you
I'm
can.
in love with this this skull. Well, as we can see here, we have customized guides. These are wonderful. And these are special guides because they are designed for minimally invasive surgery. We have very small, very thin plates. We don't need to put them in the bone. We put them in the teeth. Okay, so we don't need to perform a very large incision and dissection. We only perform a very small incision. We perform one osteotomy first, then we remove it, we do the other side, and in that way we only needed to have a 2 centimeters incision.
And also the drilling that will after be
Yes.
the key for putting the plates, moving the maxilla.
Yes, that's the secret of this, because at these holes we we mark the fixation screws for the plates. So when we mark and we drill this with these holes, when we put the plates, the maxilla goes automatically to the place that we planned. So usually we start with maxilla first.
Yeah.
Okay. About fixation and plating. In fact, I prefer to start with mandible.
Yeah.
But I don't put the plates.
Okay. You just put it on the end
do the
after
osteotomy,
you do the
then I do the osteotomy on maxilla. I put the plates on maxilla, then I put the plates on the mandible.
Okay.
So I like to start with the genioplasty, mandible, and the maxilla osteotomy.
Okay.
And I start fixation with maxilla.
Okay. Right.
That's the usual procedure with customized orthodontic surgery. This is wonderful. Wonderful.
Okay. Can I pass again to this?
Yeah, sorry.
Well,
One of the cases.
yes, this is a patient I saw a few weeks ago. He had made an orthodontic treatment. He didn't want to perform an orthodontic surgery, but he had a very pronounced asymmetry of the mandible. So we perform a simple genioplasty. You have on the next slide the virtual planning. Yes, you can run the video. And we can see the soft tissues, and we can position as we wish, as we want.
Yeah, making
And-
plans, measuring, and everything.
Yes.
Yeah.
And to reproduce with a very, very high precision the position that we choose on the computer, we can do it exactly the same on the patient.
Yeah.
And this is wonderful. The result is very important, and if we can do it with a very minimally invasive procedure, the better. Okay? So for me, this is astonishing. The technology is wonderful. But
Yeah, these plans they are defined. You can measure the several the several heights of the face.
yes. Yes, you can
Go a little bit
push
faster.
forward the oh, it's not possible.
Maybe like this.
Yes, we can do all the measures, all that we want. Yes. I like the papers from Alfaro with Barcelona line. And it's very good. And we can
Decide
decide
the
every
cutting, the
single
osteotomy.
movement.
Yeah.
We can preserve the nerve. We don't need to see it. We don't need to do the dissection.
To expose before,
Expose.
to not to damage. No.
We only need to preserve him. We don't need to see it.
Mm-hmm.
Yes.
So this is the displacement needed.
Yes,
Yeah.
that's the movement. I don't remember if this is the final planning, okay?
Yeah.
But you can
there
see
is also
the
a rotation here needed. Yeah.
yes. Yes. When we perform this with guided surgery and a customized plate, the bone goes automatically to the to position, to final position.
Okay. It doesn't.
Okay, so you don't have the plate there. So
They come.
yes. Yes, I don't have. And
Oh,
that's-
sorry.
That's
The result. Yeah.
in
With just a
In
small intervention, it's
yes,
completely
this
different.
this
person.
picture he was leaving the hospital. Okay, so it's in the same day.
Yeah, you can
Okay.
see.
In the same day, he goes away.
No edema, no nothing, so
Nothing,
incredible.
nothing. Yes, it's fabulous, fabulous. This. Yes.
Yeah, amazing.
Yes.
I didn't saw yet. I saw the planning. I didn't
Yes,
saw yet the
you-
final result. No,
Oh, okay.
no. Amazing. Very good.
Yes,
Very
yes.
good.
It was a few weeks ago that we
Yeah.
performed this surgery.
Very
It's
good.
amazing.
Yeah.
Oh, this is the paper from Klaus and David Ziel about customization. It's a very interesting paper. I love,
Uh-huh.
I love it. I love it.
So this is the planning that
This
we
is the
sent to you.
Virtual
Yeah.
planning for another case. You see the design of the plates. We only need one plate on each side of the maxilla. We don't need 4 conventional plates. Okay, these
Mhm.
plates are designed to do, and we can perform this kind of surgery.
Yeah, incredible.
And the patient goes away on the next day, happy, satisfied. This is a young patient, 22 years old. It was one of my first cases with minimal, really, truly minimal
Minimal
invasive
invasive.
surgery. It's amazing the difference. I
Yeah,
don't know
it's
if I
true.
have on the next slides the planning. Yes,
Yeah,
this
yeah.
is those.
Because you have
That's-
segmented the maxilla. Yeah, right.
Yes, yes,
Also,
Yes.
okay.
yes. It's a very
Complex case in reality.
complex, but we can choose where
To put the screws, yeah.
with more bone density. It's amazing. And this is the incision, a very small incision.
Yeah.
You can see the size of my finger, the guides, just like here, okay, just like here on the model. And we need special tools. We cannot do this technique with conventional instruments. So we need a very small and delicate tools. This is one of I have this
Kit.
this kit, so I advise everyone to take a look. Another case, sorry for the picture, it's not very good, I'm sorry, but you can see the small incision. It's
Yeah.
amazing what we can do.
Yeah,
With
it's
technology.
It's truly
Yes.
amazing in reality.
Yes.
New patient and really great. So, Carlos, I just have to thank you. You are doing me a better person, you know. Not only a better
Well.
person, but you increase my love for my job. You know, you bring me always something new. You are always pushing me. Not only you, but all my friends. They are always pushing me. They are always
Yes.
trying to put me on
Yes.
next level.
You are a very lucky guy because you talk with people from all over the world.
True.
The world. You
True.
talk with surgeons from India, from Romania, from the United States, from Brazil, from
Everywhere.
Germany, and so it's amazing the information you have. I love to discuss this case with you, and we are always connecting with other people
Yeah.
from very different realities.
True.
How it's possible to apply these techniques in India, in United States, in Brazil, a lot of in Europe.
Sure.
It's amazing. It's amazing, and trading information is the most precious value.
Yeah,
we
and
have.
filtering. I think something that we are very good is because we have a huge study club with lots of good surgeons, and we discuss it with all, and we can filter a lot all the information because, of course, we have complications, and the most important thing is for everyone to know the complications and make the filter. Okay,
Yes.
what was the cause of the complication, and never do it again.
Yes, yes.
That's the main thing that we do.
Yes.
Yeah, I think.
I think it's very important what you said, what you have just said. Complications,
Sharing
must avoid them. And
complications.
I was talking with a friend yesterday, and I told them, well, when I perform a surgery, I'm the best surgeon in the world. For the patient, I must be convinced of that. If I'm not convinced that I'm the best surgeon in the world for that surgery, I don't do it.
You won't perform it. Okay.
Okay, so I think it's a philosophy. We should all think about
Good one.
that and
Your patients
have a
love
plan
it.
A, plan B, plan C for each patient. It's very important.
True.
Yes.
Okay, thank you, Carlos. It was really great.
Thank you so much.
For
Thank
me,
you so much.
it was really amazing to have you here. We talk every day, so
Yes,
it's
yes.
it's just